Hi, I'm here with Mrs. Friel. She's been working with the mentally handicapped for a number of years and is currently an occupational therapist. So, can you tell me a little bit about your experience working with the mentally handicapped?
Sure. I'm an occupational therapist, and I've been employed within that field for almost 30 years now. And the population that I started working with was the mentally handicapped way back in the 70s. At the time, they were institutionalized, and so that was where my first career started with that population.
Okay, and could you tell me a little bit about what you did within that first career choice?
Mm-hmm. Back in the day, when I started with that population, working in that facility, they had cottages that they housed the people that were mentally challenged, and I worked in one, and the facility that I worked in was all men. They had another facility for women, but the men was the situation that I worked in, and they went from, probably the age of 5 through 100. And they would house them according to their cognitive abilities. So if you had, there's different levels of retardation, mild, moderate, and severe. And so based on their level of intelligence, they would put those men together in the same living quarters. And then the facility provided therapies to see if they could enhance their cognitive development, meaning occupational therapy, physical therapy, speech pathology, and then some ongoing recreation therapy to increase their social skills.
Okay, so what would you say the determining factor is for a person who has mental retardation? Like, how would you be considered mentally retarded?
Generally, there's a psychological test that's given by a school psychologist or a psychiatrist. There are a number of neurologic disorders that cause mental retardation. So it isn't just Down syndrome, but you can have neurologic brain bleeds as a baby. You can have some head injuries that can cause you to become mentally challenged. So based on those conditions, then they provide these tests, which give a baseline of intelligence or an IQ quotient.
Okay.
And so that then will allow us to have some feedback about where their level of learning starts. So as a therapist, we can interact with that patient based on the level that they are and come up with activities that will hopefully, enhance their cognitive abilities to socialize or participate in their activities of daily living.
Okay. Now, do you know, you said the cause was like a head injury or stuff like that, but is a person born with it, or is that something they grow into?
There are some genetic disorders that are obviously in utero. Your genetic makeup didn't, produce the way that it should have, which causes a genetic anomaly, and that then can have I just wanted to be sure.
You're fine.
That then can have an effect on your cognitive abilities. So depending on whatever the genetic component is, that will give us some feedback about, since there's been research done on certain genetic anomalies, what the level of function may be. Of course, when you're born, your brain is still growing. So you have the opportunity at a very young age to try to make those brain cells better, which is why therapy is so valuable. Because if you can enhance their development while their brain is still growing, that's wonderful. If you have a brain injury as an adult, then your level of functioning never regains because you just don't regrow brain tissue.
Yeah.
So to answer your question, yes, you can be born with something. We know about it in advance if it's a genetic disorder. Most of the time there's some testing that's done in utero. There are also some other conditions, Down syndrome, which affect the mental capacity of some children. And then if you are born and have an insult to your brain because of prematurity, then that also can be a predetermining factor. In addition to spina bifida and cerebral palsy and cleft palate, there's a number of predetermined conditions that will affect your mental capacities.
Okay. And you were talking about the cognitive skills that these patients came in having. What were some of their things that they couldn't do?
Sometimes it depends on the level of the disorder. So for those that are mildly handicapped, typically they can learn how to do the general things in life. They can be taught through structured certain ways to dress themselves and feed themselves and function in an environment and maybe get a job of some kind that's not maybe as cognitively enhanced as what you or I could be able to do, but at least trainable.
Yeah.
And then if you have somebody who has more of a moderate deficit, those are a little bit more challenging because typically there's some behavioral functions that occur. So those children or people usually don't have a great communication system or foundation. So because of that, they get easily frustrated, and you'll see some acting out components that make it a little bit more challenging as a therapist to try to help those people accomplish the basic tasks. Yeah. And generally always will have to live with some kind of provider or caregiver, or maybe in a group home where there's other children or people their same age. And those that are severely handicapped generally require more one-on-one contact or with a caregiver. You don't ever really see them living alone or able to hold down a job. They just, once their intelligence testing comes back, the psychiatrist or the psychologist can give us some feedback about where they are in terms of their IQ quotient, and then we'll know that unfortunately, we've maximized their potential and, hopefully give them some sense of self, and maybe even if it's just the ability to play or whatever makes them happy and comfortable, and keep them in an environment that's safe and protect them from hurting themselves or others.
Okay, so you were saying that those men lived in quarters within other men with the same mental capacity. Mm-hmm. How were their social skills? How did they interact with one another?
Well, the facility did a lot of things to try to make sure that those men had the opportunity to socialize and not be too competitive, but yet still interact with functions. And often they would have the state school that was for women provide some like dances or hay rides or things that were a little bit something more social, like you and I would do for certain special occasions, holidays and stuff. And so it was always supervised because there is a tendency, with hormonal changes at certain ages for people to become aggressive. So you had to be careful and monitor some of that. Some people would reach a certain level of age. Say somebody just maximized their potential at the age of 14. So obviously then they're always going to be obsessed or predisposed to some kind of sexual contact. And even though they may be 80, that's still how their cognitive level is functioning. So you had to kind of always be aware and sort of, kind of get a little bit a distance between them and sort of try to manage that so that they were more appropriate. But in general with each other, of course, with men, you can find them to be more aggressive than females would be. So that kind of sometimes, people, depending on what the issue was, could get a little bit abrasive. And so you had to intervene quite a bit. But for the most part, their social skills, since they paired them with those that were of the same level of intelligence, were relatively good. It's like living in a dormitory room with people that were your same age. You can get those personality conflicts that occur, so you can try to do some intervention and see if you can counsel and try to get them past that issue. And if it's going to be a continuous conflict, then maybe think about relocating them to a facility or a different cottage that was more appropriate and avoiding those continuous conflicts.
Okay. And what were some techniques you used to communicate with the mentally handicapped?
As a therapist, we worked closely together. We did what we call multidisciplinary therapy. So it wasn't just sometimes an occupational therapist. If my goal as an OT was to help this person dress themselves regularly, and I couldn't really, visually show them because they wouldn't imitate for me, or say that's all they did, but the speech pathologist was working with them too and really wanted them to communicate or me to be able to give them a directive versus just constantly imitating the task. Then we would work together, or what we call co-treat. So she would, sometimes there was sign language that was used if somebody just didn't have the ability to just mouth those words. Some people are echolalic, which means that they say whatever you say, so they're repetitive. So I would say, it's time to get, to dress your, to put your shirt on. They'd say, it's time to dress your shirt on. And they'd do it kind of sing-songy. And even though it was funny and cute, it really wasn't accomplishing the task. Yeah. So you had to kind of work with this clinical psychologist with, function and routine, see if they could read. If they can't read, then the next thing, of course, would be gestures. And so depending on what their level of intelligence was, the speech pathologist would tell me what she was doing in order to get them to verbally respond with a communicative directive versus just the imitative directive. And so we would kind of keep that in mind as we go through the therapies, whatever kind of therapy that patient is getting.
Okay. And this is something that obviously can't be cured or anything like that?
Unfortunately, no. I mean, we talked about with the brain development, and I think that, so valuable. I think the current research has shown that the more you provide that stimulus at a young age, the better you possibly have of maximizing their brain growth. So now early intervention has become the rage. And, since that time that I was employed at that age, with that population in the 70s, the whole approach has kind of turned around a little bit, which has been really wonderful for families. At that level, there really was not the interaction with the families. It was more of a, this child is too much for us to manage in our environment with our other children or our household. Or, if they grew up and became aggressive because they were in that stuck in that teenage mental capacity year, and they were just out, always, there was outbursts of behavior that were scary because they're big men, even though they're only 14 in their mind, they're 50 and big and muscular. So there was always that, let's separate them from the natural environment. Where now they have closed a lot of those facilities, and so they've incorporated these young adults and older adults into the community in group homes or housing, so that they're not ostracized and put in a state institution. So since then, it's the to answer your question about whether you can cure it, I think that having had that opportunity to maximize their potential at a young age isn't necessarily a cure, but it certainly has come a long way in helping them get as far as they can in their development at the very young stages, versus wishing we had done some early intervention at a younger age.
Okay. Well, that's all we have. We really appreciate you sitting down and answering our questions.
Certainly.
Thank you so much.
You're welcome.